So what I hear, we all are here to discuss child psychiatry neurodevelopmental disorder called ADHD. So as with every topic, I'll discuss this under following headings: definition, epidemiology, etiology, diagnostic criteria, comorbidities, management, and what I'm adding a new thing which I didn't discuss in the previous sections, that is treatment guidelines, recent treatment guidelines. I've gone through all the guidelines. Hello Aditi, good evening. And I have prepared a summary for you, and I wish to deliver it today because once again, as with my most of the classes, today also I have more to deliver, because I don't know why, but sometimes I miscalculate the amount in proportion to the time I have to deliver. There's nothing to hide from you how I am preparing these lectures. First, I open my own notes which I made during my MD days. Then I feel these are insufficient and I should add something. Then I read synopsis, CTP, Rutter, so whatever I feel, I keep on adding. And in the end, when I plan to, I make a copy and then I wish to deliver everything. But some of the points still, I feel that are missed. So today I wish to focus more on this management and treatment guidelines, because let me tell you, all of you are going to see ADHD patients in OPD. As I always mention, psychiatry is two types: GHPU, General Hospital Psychiatry Unit, and mental hospital setup. Unfortunately, ADHD is one patient which is very less likely in the mental hospital setup. So there might be a few students among you, especially first years or even final years, who have seen a disproportionately less number of cases of ADHD. In fact, generally what I've seen, the students are not confident with ADHD management, because Ritalin, Inspiral, whatever you call it, methylphenidate, is one of the Schedule H drugs. So it is one of the two drugs which is to be given only by a prescription by a psychiatrist, pediatrician, and the pharmacist has to keep a copy of your prescription in order to dispense. There are a lot of things. And I've seen people not very confident in prescribing methylphenidate. So today what we are going to discuss will not only be important for your theory and practical examination of MD, but what I believe is, after I end the session today, and suppose tomorrow you see an ADHD patient, you should be able to diagnose. Diagnosis is not that difficult in ADHD, you catch it very easily. And you should be able to prescribe medicine appropriately, aptly, with correct dose, correct formulation, correct guidelines, correct instructions. What I feel is you should know the arts of practicing also. I've been practicing in Delhi for like 5-6 years. Before that, I was practicing elsewhere. So what I've seen is ADHD management is not that easy as we feel it to be. And in private practice, ADHD patients are more as compared to government setup. Do you agree? Do all of you have exposure to a patient of ADHD at least once or twice or maybe 3 times? In first year MD, when ADHD patient used to come, my third year senior used to try to see it himself and not allowing, myself to intrude, because I was too much of an intruder type of a person. So, but eventually in second year of MD, I picked it up. I'm once again telling, it's not the diagnosis which is difficult in ADHD, it is the management. Alright, where to go for pharmacology, where to go for non-pharmacology, when and how to write the prescriptions, and when to give methylphenidate, when to give atomoxetine, what is the role of clonidine, bupropion, etc. And today I am planning to discuss treatment guidelines. As I mentioned you on WhatsApp group, etiology, the major portion is neurobiology. This topic is given less in Kaplan. So I have made notes on this chapter and uploaded in this biology of ADHD. How many of you have seen it? My request is to please see that lecture. Reference stall. In that lecture I have used most of the information from stall. Has anyone seen? That was my first lecture for residents. When I planned that I will take lectures for residents, that was my first lecture. I have even uploaded it on YouTube so that everyone can see what I'm trying to deliver. Because biology of ADHD is itself a 10 marks question. And there are certain 10 marks questions which are not solvable from Kaplan, and biology of ADHD is one of them. Have you seen? Did you understand that lecture? So that was the one of the 2 pre-recorded lectures given to you. Otherwise, most of the lectures in this series 8 are live lectures. Those 2 are pre-recorded. Did you understand anything from that? So let's go ahead. I'll refer to biology as and when needed. I assume that you have seen. ADHD is a neurodevelopmental disorder characterized by problems in sustaining attention and or hyperactivity impulsivity leading to significant impairment in academic performance, social and interpersonal relationship. If you have noticed me and my teaching, I always focus on telling you the definitions. It might sound very childish or kiddish as a part of MD teaching, but what I feel is a consultant psychiatrist should be able to tell the definition of a psychiatric disorder like schizophrenia, depression. Everybody speaks about clinical signs, symptoms, features, identification criteria, but very few people speak about definition. Suppose a layman asks you what is ADHD, so you should know the definition to explain him. And please remember, as a resident, you are not supposed to say ADHD is attention deficit hyperactivity disorder. This even MBBS students know very well. So if you say ADHD is attention deficit hyperactivity disorder, and suppose I am your examiner, I will definitely fail this resident. That means this resident knowledge is not at the par of MD. He is still having psychiatric knowledge at the par of undergraduation. So don't tell me the full form. Everybody in this country knows the full form of ADHD nowadays. Okay, I'm overgeneralizing, but most of the people know. So please remember, it is not just attention, it is and or. Okay, so we can have a pure attention ADHD, ADD, attention deficit disorder. We can have only hyperactive impulsive without even attention deficit. So it is not and, it is or, and it has to have an impairment in academic and social interpersonal relationship. Do you get it? Because there are normal children who are hyperactive, but it doesn't cause any impairment in their academic performance, we do not call it as ADHD. any child who troubles the parent, a dictum by myself, any child who is difficult to handle by the parents is not ADHD. Please mind it. I've seen people over-diagnosing ADHD. And I've seen residents, using these words among themselves. Suppose you told your colleague PG, especially your junior PG, do that investigation or do that MSc of that patient on bed number 14, and he forgot. And I've seen one resident telling other resident, are you ADHD? You don't remember anything? Don't use this as an adjective in the ward. अरे ADHD है क्या? ओके ऐसे मत करना. किसी को भी सड़क पे चलते फिरते ADHD बोलना एक साइकेट्रिस्ट को शोभा नहीं देता. ठीक है. We are not the people who will diagnose just like that. We have some our rules, criteria laid down. So let's understand. Epidemiology. It affects 7 to 8% of elementary school children, primary school children, approximately 5% of youth. Youth means child, adolescents, and approximately 2.5% of adults, because it's not just a disease of children, even adults are affected. Reference Kaplan. If someone asks you what is the reference of this data, there's another theory given on epidemiology that let's say 5 to 8% of school children meet the diagnostic criteria of ADHD. 60 to 85% of them meet the diagnostic criteria as adolescents, and 60% of them meet the diagnostic criteria as adults. So if they ask you prevalence of adult ADHD, it is 2.5%. But if they ask you what percentage of children ADHD convert into adults, then it is 60%, because 40% have remission by adulthood. Do you get it? Because there are some students here preparing for MCQs as well. Do you get it? अगर 100 बच्चों को ADHD है तो उसमें से 60 ही एडल्ट में क्राइटेरिया मीट करेंगे, बाकी 40 ठीक हो जाएंगे. And I think by this time you must be knowing all adult ADHD are not adult onset ADHD. They are remnants of childhood ADHD which went progressed to adult ADHD. Adult ADHD can't be adult onset because the onset has to be before All India PG MCQ. All of you have cleared these exams. All India PG, NEET PG. Onset has to be before